What's up, guys? So I just finished editing. I was getting ready to upload it. I realized I didn't make a beginning. So that's this. Not very good, but I'm trying. And I would appreciate it if you tried to just click the subscribe button. I would appreciate it. I know many other people would appreciate the algorithm to get this information out to more people. Anyway, enjoy the video and please be respectful to Dr. Kristin Pettit and our interview, my time with her. Thanks. So we're here with Dr. Kristin Pettit at University of Michigan Hospital again, and go over a couple questions. Um, First, this is kind of something I want to know. Why did you choose an MPN to study? Like, how did you get into this field?
I think it was a combination of things. So when I came into medicine, I really didn't know what I wanted to do.
Yeah.
I liked taking care of people I liked taking care of people over a long period of time. I didn't like having just like a temporary connection to somebody and then passing them along when they got better or something like that. I liked taking care of people for a long period of time at a really crucial moment in their life too. So I think oncology is really the place where you get those really strong connections.
Yeah.
So that was one reason. Another reason was a patient actually that I met early in my intern year. So had my MD for 3 weeks probably, and met a patient who had myelofibrosis, and she had a really large spleen. She was very symptomatic, and she and I just really had a connection. And it was right around the time where JAK inhibitors were, gaining momentum. And she started on a JAK inhibitor, and we got to watch her spleen shrink beautifully and her feel so much better. And she went on to a stem cell transplant and was cured afterwards. And she's written a book about it, and she's a really amazing and inspirational person. So
That's awesome.
a lot of it was, I think, my personality, fitting, and my long-term goals kind of fitting with this field. And a lot of it was an early on experience. So I think for anybody out there, you can have a big impact on on people's lives. So if there are trainees or medical students, early doctors that are rotating through in the clinic, those people, you could make a really big impact on them, and you're their major teachers.
That's awesome. I know, for me, going through the medical system, you almost feel like a number sometimes. Mm-hmm. But when I came here and started working with you, that was kind of gone. So you definitely, you're good at not making me feel like a number.
Thank you for saying that. That's really nice.
It was cool that you said something about the stem cell thing, because there's this little conversation that's been going on online about, this is kind of a few years down the road, but getting into CRISPR. And I know we had kind of talked about it at one point, that there's just that one marker type thing that could be done. Is there any news on that, or something coming forward that could be a possibility in the next 5-10 years, or whatever?
Yeah, gene editing I think is a exciting but complicated field to get into for sure. I think these diseases, some of these diseases are good candidates to consider that in, because like you said, some of these are single gene diseases. The problem is one of the problems is when we get into the more advanced phases of these diseases, so myelofibrosis or leukemia that can happen for some people. Typically there's more than one gene driving the disease at that point. So then it gets a little bit complicated. And if we were to use something like gene editing earlier, when there is probably more of a single gene driver in ET and PV, the risks might not, balance out with the potential benefits. So it's a little bit of a tough situation, I think. And I think just medically, ethically, legally, all of those ways, I think we're a little ways away from it still. But, it's being done certainly in animal models, and it's being tested quite a bit. So maybe for the future, stay tuned. But
that's fair. What's the main thing to do after diagnosis? Because I know there's been a few people that they just got diagnosed and they're working with maybe a hematologist alone or only a primary care. They don't really have somebody specializing in it. So kind of what's the best path for people to take after an MPN diagnosis?
Yeah, I think everybody's path is so different with these diseases. That's one of the reasons why these diseases are so tricky and so interesting, because they are so different. But I think for that reason, for a lot of reasons, I think it is important, if possible, to seek out an MPN specialist. I am not saying that in meaning to say that in a self-serving way
Right,
by
yeah.
any means being an MPN specialist, but the field has come a long way in the last few years as far as understanding these diseases and having new treatments, clinical trials, some other new treatments that are just out there and available that aren't even clinical trials. So I think it's important to establish care with somebody that you trust for sure and that's accessible and close to home for sure. But if you don't have an MPN specialist that is close to home, accessible, and that you trust necessarily near you, I think it's important to seek one out for at least a one-time visit to make sure you're on the right track, make sure you understand about your diagnosis, you know what you're looking for, the right things are all being done, those sorts of things. And most hematologists and oncologists and primary care doctors in the community welcome and are grateful and appreciate those kinds of consult appointments. So I think that it's worthwhile to at least have one visit with a specialist and make sure that everything is all right.
Yeah, for sure. I didn't even think about doing like a one-time thing.
Yeah.
There are like, even like through like the groups and stuff online, all the questions are very simple, like rudimentary, but like they're going off of, doctors that aren't specializing in it. So the one time would be really cool.
Yeah, and I think now with COVID too, now virtual appointments are more of a thing too.
Oh, yeah.
So sometimes you can do them virtually. Crossing state lines is sometimes iffy. Some places will let you do it, many places won't. But you might even be able to just do like a virtual consult to make sure you're on the right track.
Nice.
And make sure the diagnosis is correct too. There's so much overlap between these different conditions that having somebody who can actually look at the pathology or look at your numbers and everything else and make sure everything fits, I think is really important.
Yeah, that goes into like my next question is with like the bone marrow biopsies. When are those necessary, first of all, to like actually have like an MPN diagnosis? Because there's like secondary, primary, kind of. When would you go about having something like that, like further testing beyond like the genetic JAK2 testing?
Yeah, it's a really good question. So since you brought that up, we had a call recently about something completely different, but it was MPN specialists from all over the place that were on this teleconference, and somebody did like a little poll: who does bone marrow biopsies for all patients with suspected ET and PV, or who thinks that there are cases where you don't necessarily need it, and it was 50-50.
Really? Okay.
So
all right.
Technically, if you're by the book, you need a bone marrow biopsy to make the diagnosis according to our formal criteria for ET, PV, myelofibrosis, any of these things. But at the same time, there are certainly situations where you might not want to if the patient doesn't want to have one, where you can be pretty confident about the diagnosis just based on the genetic testing and based on the lab work and the physical exam. But reasons to do the bone marrow biopsy: first of all, to formally make the diagnosis. Secondly, to rule out early myelofibrosis in some of these conditions too. Occasionally when you're pretty sure somebody has ET or PV, you do a bone marrow biopsy, you see a little bit of early scar tissue in there. It doesn't necessarily change the immediate management, but it might change how closely you're monitoring things down the road. And then also to get the cytogenetics, to actually look at the chromosomes under the microscope. That's really hard to do from the blood. The cells don't grow as well. So really we need bone marrow samples to do that too. And again, it's pretty rare that would change the diagnosis or the management. But it is possible. So for all those reasons, I usually do it at diagnosis, unless it's pretty clear cut and the person has an aversion to doing a bone marrow biopsy.
Yeah. All right. And then with platelets, like concerning with platelets, especially like with my leg, for a second, because Google made me think it, I thought there was like a cluster of platelets like clotting or whatever. But it seems like working with like you and other previous like doctors prior, I've never worried about platelets. A lot of other people are worried about platelets being in that like 400 to 500 range or whatever it is, and then it fluctuated. But I've never actually like paid attention. So how important are platelets? Like the count of them,
Yeah, it's just one of the factors. So there's so many factors of these diseases. So certainly with these conditions, blood clotting is what we really worry about for many people. And platelets are, of course, what goes into forming the blood clot, but they're not the whole story. So we know that having an elevated hematocrit or an elevated white blood cell count also increases your risk of having blood clots form. And even if you get all the numbers down to completely normal, perhaps just having that inflammation there in the background probably contributes too. So it's a combination of all of these different things. And actually the opposite of what you would expect. If the platelet count is really, really high, like above 1 million, whereas we're usually normal is 150 to 400,000. If it's up above 1 million, you would think that maybe people would be really prone to blood clotting, but it's actually the opposite. When the platelets are super, super high, bleeding is actually more of an issue as opposed to clotting. So the number just tells one portion of the story. In many people with ET, we try to get the platelet count down, but we don't have a set goal. Some people will say it should be normal. Some people should say it should be about 1 to 1.5 times normal, somewhere in there. So our goals are not as clear cut as they are in PV with the hematocrit level.
Right. Seems like nothing's really clear cut.
Nothing is clear cut in these diseases.
Yeah,
No.
it's awful.
Yeah.
So that's perfect for the next question. The biggest question that I know, like for me, like I don't do a lot of stuff on social media, except for like this thing, but like randomly I'll put like pictures of like today like running with my dog. So people are wondering how I can actually run with it because of fatigue.
Mm-hmm.
And I know for sure fatigue and brain fog are 100% my biggest things. I haven't found like any shortcut of like, oh, when this happens, here's how you fix it type scenario. But are there any kind of paths we should try to stick to, or like things that we can do, supplementation, like diet, hydration, sleep, obviously are like top of the list, but is there any hacks that I don't know about or anything?
It's so hard. It's so hard because everybody's so different with these diseases, and everybody is really individualized. Some people have clear-cut triggers, like, hey, if I do this, I notice this. You know, like hot water and itching. You know, that's the case for a lot of people. Some people it's certain foods and then feeling really fatigued or itchy or, you know, whatever else. So if you notice those triggers, obviously try to avoid them if you can. If you notice anything that's opposite of that really helps you feel better, then obviously it would gravitate towards that. But it's tough. Fatigue is the number one thing that we hear about with these diseases from patients, and it's the most severe thing that we hear about, the most frequent and the most severe. And it's tough to manage. I think I mentioned this last time that I think that exercise, cardiovascular exercise, I think yoga, I think good anti-inflammatory sort of diet, like general heart healthy sort of diet, I think can all help to some degree. And there's a little bit of actual evidence and data for all of those things. But really it's got to be personalized. Whatever, you know, I hate to say it, but it's kind of trial and error. Whatever helps you feel better is what you particularly should do. And I don't have any brilliant hacks other than listening to your body.
It'd be nice if you did.
I know, maybe someday.
Yeah, for sure. Yeah, I think that's it. I don't